right, can everyone see my slides? Perfect. So I want to go over just a brief history of neurodisparities. And just a quick disclaimer, we are all here to learn, discuss, and challenge the status quo together. Please feel comfortable speaking your mind, and also please be respectful and empathetic to those around you. So some of my aims for today, I want to talk about the dehumanizing historical beliefs that have existed in neurology, as well as some of the unethical historical events that have happened. And I want to expand on those and recognize how these have negatively impacted our current communities and how to address the repair that these harmful events and beliefs have caused. So I really want to make this abundantly clear. None of these claims are true. So what I have listed on the slide here are some of the really dehumanizing views that have been held about women and Black people. Samuel Cartwright came up with this nonsense in the 1800s that Black people have larger nerves. There's no factual basis on that. And that belief, this biological difference between white and Black people, was used to describe that Black people had lesser responsive nerves and felt pain less. That is a terrible idea, because what ends up happening is Black people receive pain relief, sedation, and all kinds of things at lesser rates. This isn't specific to neurology, but we know that the father of gynecology would perform really terrible procedures on his slaves without giving them anesthesia or any kind of pain relief at the time. The other one, the women are emotionally fragile, is a general stereotype from all of history and is a pretty relative constant amongst patriarchal societies. I would not be able to tell you who came up with that, just that it's persisted throughout history. So keeping those beliefs in mind, the first thing I want to talk about is multiple sclerosis or hysteria. So in 1868, Charcot initially recorded multiple sclerosis as a neurologic disease after performing an autopsy on a brain of a patient with suspected MS. Once doing that, they saw the plaques on the brain, and a subsequent series of lectures were given to educate people about what MS was and how it can present. However, misdiagnosis with hysteria was really common in women with MS for the early 1900s. At that time, men were more likely to be diagnosed with MS, whereas women with the same symptoms were more likely to be diagnosed with hysteria. And we know today that the predominance of multiple sclerosis is actually in women, a 3-to-1 ratio. So that difference in diagnosis is kind of devastating. There's an article about a woman who she has MS, and she had symptoms back in the 1980s, and she went to the ER, and the physician there asked her, "Oh, do you have panic attacks?" and tried to write off her symptoms as anxiety or depression, rather than listening to the potential neurologic issue. So even to this day, we see that women are much more likely to be misdiagnosed, to have delays in their care, and just be undertreated in general for illnesses like chronic fatigue, lupus, and even Parkinson's. So after telling you all this, I just want to know what your initial thoughts are. And feel free to unmute yourselves and speak freely.
All right, so I'll just go first. I think it's interesting, talking about MS and hysteria in women. I think there's some things in medicine that are still pervasive to this very day. If we think of all of the STEM questions for, like, malingering in a hospital, it always starts with a female patient or a female medical student. And I think there's a lot of embedded sexism and also racism within medicine that still persists to this day, even if we don't think of it as blatant as it was back then, it still exists. If there's, on the USMLE, if there's a question stem that begins with a homosexual male, it will always involve sexually transmitted infections, right? So there are certain biases that are really taught to us in medical school and have been taught to us really in the creation, I think, of like the medical system in the Western world. So part of our job is to try to recognize our own biases that exist so that we will do better really in taking care of the patient. That's all I'll say.
Thank you for that.
Mm-hmm.
That's actually pretty well said. It leads into my next question beautifully. So what role does implicit bias play in the presentation of neurologic illnesses?
So yeah, and everybody who's in here right now, please feel free if you have any thoughts or comments or anything. We want to make sure that this is a conversation as much as an educational event. So please feel free to talk to us about what you think. So from my take on this, and y'all can hear me, right?
Yeah.
All right, great. So I also think there's something else interesting to talk about here too, which is still some of the stigma surrounding, mental illness or like behavioral disorders as well, in addition to, the inherent sexism that we've really witnessed here. I think this year for one of our sign events, we hosted a young woman who had, an NMDA receptor autoimmune encephalitis. So something that presents very similarly to schizophrenia. And she ended up having a very bad experience at her initial presentation because the ER that she went to treated her kind of, roughly as a mental patient effectively, and kind of refused to transfer her to another institution where, just to see her acute presentation. Her parents ended up driving her, across to a different city in order to get her addressed. And there they found the antibodies and all that and got that settled. So I think, in addition to the blatant sexism here that you can really see, there's also the issue of mental health stigmatization that some patients that we're really quick to judge those who seem to be acting differently or erratically, even something simple as like hysteria, which is commonly held belief at the time that's been since disproven. It's definitely something to consider.
And then even in your slide one of the claims that you said was not true was the one that, Black people feel less pain overall. And I think it's interesting that this was started in the 1800s, but really in medicine, this belief sort of exists still, which was proven in a 2016 study in the Proceedings of the National Academies of Sciences, where they surveyed trainees, actually, so medical students, and found that medical students held one or more false beliefs in regards to pain versus Black patients versus white patients. And actually, in that survey that was recently, in the last 5 years, 40% of first and second year medical students actually endorsed the belief that Black people's skin was thicker than white people's skin. And they had medical students actually treat, fake patients in this part of this survey and study. And Black patients received less pain medications compared to white patients. So these beliefs aren't really long forgotten relics of the past. It's really still ingrained, I think, in society today.
Absolutely. A personal experience of mine, in my third year on my internal medicine service, there was a young man with sickle cell syndrome, or sickle cell disease, excuse me. So we're in New Orleans. The sickle cell clinics here have been closed for a pretty long time, basically since Katrina. So he did not have anybody who provided him care consistently, and he was in the hospital for a pain crisis. And I kid you not, it was a daily battle with the nurses to give him the appropriate amount of medication. They refused to give him his Dilaudid. They called him opiate dependent. And of course he's opiate dependent. He's in agonizing pain. He needs something to get through the day. And every single day, the attending I worked with, me and her would go down there and have to explain to the nurse, like, hey, he really does need this. He might not tell you that he's in a lot of pain. He just says the number. But just because he's not screaming and crying or whatever pre-existing beliefs you have doesn't mean he's not in pain. So that was very frustrating. And I remember I followed him every single day for 3 weeks. And I told him, I'm real sorry these people are doing you dirty like this. And that was the first time I saw him smile in 3 weeks. I don't know where he is, but I hope he's doing all right.
Yeah, that's pretty common, I think, in the sickle cell population. Sicklers in the hospital, I think there's always the eye roll when they ask for pain medications, even though we know that they have a good reason to be in pain. And I think part of the problem, if not a big part of the problem, is really just the skin color of a lot of our sickle cell disease patients in terms of actually providing them the care that they need. Yeah.
Yeah, I've actually seen this quite often. I totally agree with Victoria. I was doing my 3rd year clerkships in the Bronx, and it was almost frightening to see the amount of patients that we had coming in for, actual issues that required pain medication versus patients who came in for like drug-seeking behavior or like et cetera, et cetera. So I think the implicit bias is there. It absolutely is there. But I think a lot of the healthcare personnel just become so desensitized to it all that they kind of just think, everyone coming into the ED, asking for Dilaudid, like Victoria was saying, is immediately just drug seeking, when, it absolutely is not always the case.
You mentioned something really important, that drug seeking term. For this, my patient particularly, he had drug seeking, just a big red flag in his Epic chart. And that primed my interaction the first time, because I was like, oh, why would they put that? And it was such a difficult process to actually get that removed from his chart. And I genuinely believe, on top of like implicit bias, that kind of played into why he wasn't getting his pain relief, because someone somewhere stuck that tag on him and just set him up for just being in pain and not getting his pain treated.
Yeah, and he was in fact seeking drugs, but for something very legitimate, something that does require, aggressive pain management. So to kind of write something like that in the note can already be off-putting to anyone reading it that doesn't even know the patient. So you're just automatically like, if you had a long day, you've been working like 20 hours, you read this note, you're just going to be like, oh, okay, another person with drug-seeking behavior. And so that kind of vicious cycle just has to stop. And I think it's just a systemic problem.
Absolutely. It's very, very frustrating how we're so quickly primed by this like electronic medical record in our labels. I do want to, does anybody have any more thoughts or things that they would like to share before I jump into the next question? Okay, so our next question, how does systemic sexism impact the delivery of effective neurologic care?
I think it can be easier for someone to kind of tag a patient as a functional patient rather than an actual patient requiring neurologic treatment because she's a woman. So there can be, some women who, if they're having like a frontal lobe seizure or something, they're going to be very emotional, very erratic, very disorganized, and someone can automatically just be like, oh, it's psych, or it's just not, related to neuros. So I think I've seen that more so with women than I've seen with our male patients. So it's definitely there for sure. And I think it does impact the delivery of neurologic care quite significantly because, like, we were mentioning, there is that implicit bias within healthcare in general. And so you're applying that to a patient that's, either being acute with something neurological, or they might not be, but it definitely is there for sure.
In the slide I showed previously, we saw that women are less likely to receive adequate care. And this is just not neurology, it's within healthcare in general. It's pretty pervasive. And when we talk about the delivery of effective care, I think it's also important to mention the people providing care. When we have female providers that are neurologists, patients would be less likely to listen to them. And I think that the patient not trusting a female physician makes the effectiveness of the care that they would deliver a lot less.
Absolutely.
It definitely goes both ways. Hopefully it's getting better. We're seeing that there's more women in medicine currently. So hopefully people will recognize that girls can do medicine.
Yeah, for sure. I mean, I've experienced this myself like several times. Just being a med student, you know, people would think that I'm either like the nurse helping the patient, or that the male PA student is the doctor or something like that. So it's definitely there. I've experienced it myself, and I think, well, I hope with time, as we see more women going into medicine, we can kind of put an end to this, because I do think women are handling it very well, but you know, it is still prevalent, that's for sure.
Yeah, I will not deny that. Anybody have anything else they'd like to add before we move on? All right, let me jump to my next slide here. Where's my computer? Oh. All right. So, the next thing I want to talk about is Roberts-Bartholow and cortical stimulation. So Miss Mary Rafferty was an Irish immigrant and domestic worker back in the 1800s. There's speculation that she may have been an employee of Bartholow, who was a physician at the time, but this hasn't been verified. So when Mary was an infant, she suffered burns to her scalp, and as a result, she could not grow hair and wore wigs. She eventually went on to develop a non-healing ulcer as pictured, that became so severe her skull had eroded, and you could see, and I quote, the pulsations of her brain. She was pretty much deemed incurable at that time, and Bartholow, a physician born in Maryland, wanted to prove that the cortex was electrically excitable. And he asked Mary, would you participate in this study? It's unclear how much he explained to her and what it would entail, but apparently she consented to this experiment. During the course of the experiment, her vitals were never taken, and what ended up happening to her is she had like needle electrodes put into her brain. It's not clear what those electrodes were, or the extent of them, or what they looked like, or what tools were being used. It's just that he did that. She was said to have experienced pretty significant pain with the manipulation of her ulcer, which makes complete sense, but no pain with the manipulation of her brain. Still makes sense. So Mary, where's my thought process? So by the third day, Mary began to rapidly deteriorate. She was being shocked by both alternating and direct current, and she became depressed. She had pale blue lips. She ended up developing like right-sided paresis and really bad numbness and tingling. She eventually just became barely conscious and would have these rhythmic contractions on the right side. And when they brought her down to the experiment for the fourth day, they gave her chloroform until she stopped with her contractions. But again, they make no mention of any comfort measures or what was being done to make her feel better, or at least more comfortable. Finally, on the fourth day, she just was no longer able to speak. She had this 5-minute seizure on the right side of her body, and then we don't hear anything else other than that she died. There's no description of how she died or why she died. Bartholow went on to perform her autopsy, and after doing all this, he recorded his claims about the cortex actually being electrically excitable, and went on to become an educator in medicine, which is kind of concerning that somebody who showed such callous disregard for a person would go on to teach future generations of doctors. What are some of your initial thoughts just about this procedure in general?
Yes, the first thing, I guess this isn't really surprising, right? Just given the history of medicine, it's always been a lot of medical advancements have taken place using the other. That's what I would say, meaning either African Americans or, Puerto Ricans or those with intellectual disabilities. Like even the hepatitis vaccine was created. Basically by testing it out in a school for children with intellectual disabilities over a 15-year period. So we already know about Nazis too during the 1940s, and there were human experiments in prisoners that have all, they have led to medical advancements, but they're all rooted in these unethical practices, basically. Which is the reason that the Belmont Report came to be in the 1970s. So I'll just say not surprising. And this is really just a pattern, within medicine itself.
Yeah, that was the disturbing thing when I was putting these slides together. It was just, there were so many instances of dehumanizing vulnerable people and just treating them like test subjects. And I feel like that kind of idea of almost taking a step back and not seeing patients or subjects or participants as human, as just an experiment, you kind of see that in the apathy some providers might have to their patients today. And I think when we try to make things, how do I say this properly? Science is great, but it has the tendency to lose the human aspect of it. And I feel like if we do that, we get into these situations where we commit essentially atrocities to vulnerable people. So that kind of leads into my next question. How do we reconcile our appreciation for medical advances when they have roots in unethical or ethically ambiguous human experimentation?
I think really that's a really good question. And I think it's a very complicated question too, because like you mentioned, the long history of all these atrocities against, African Americans, against those with mental illnesses, et cetera. It's just so long, standing that, you can't deny it. It did happen, and it happened for quite some time. So I do feel like one of the things that we can do is recognize that it did happen. It's not something that you can just shove under the rug and act like it didn't happen, just forget about it. I think recognizing that it did happen and ensuring that something like that doesn't happen again by implementing things within our own institutions where we're all going to be practicing is, I think, really the ultimate way of reconciling it is just, having that I guess the best way to put it is having that type of recognition of what has happened in the past.
In the paper about Mary Rafferty, at the very end, the authors made a point to mention like the sacrifice that she made for us to go through to get these advances. And you're right, we can't look away from this. You cannot brush it under the rug and be like, oh yeah, they did that. That's just how they were. That's not how it works. These people became our educators. They created the culture. They contribute to the culture of medicine and research. So not shying away from it doesn't help. I'm a very big fan of real talk, and I think this falls into that category. And really just admitting like this was not okay and creating those written protections to stop this from happening again is really the only way forward in my eyes.
Yeah, I think it's all about just accountability, and on, from that point forward, what are we going to do as, the medical field in general to ensure that these things don't happen again while still, going through our medical advances and, research and et cetera, et cetera. And I think one of the things that we can see, like kind of in real time that happened before our eyes was the COVID-19 pandemic, and just seeing like the complications among those who are marginalized, and just seeing the impact that COVID-19 had on them versus those who came from, a better area of America or had better access to healthcare, and so on. So I do think that there's definitely a lot of work that has to still be done.
COVID definitely highlighted something that marginalized communities have been screaming about for generations, that they don't receive equitable care. And you're right, COVID made it so that we couldn't shy away from that. We have to address that there's a problem. So before I move on, anybody have any ideas, questions?
I just have one thing that I think is always interesting in relation to this, just how I feel about online medical education really having a role in all this as well. That it's an easy way to disseminate, all the information available to us, specifically with context in the case, like ethically ambiguous experimentation, that we can learn more about not only the victims and the people who have been put through all this stuff, but also, kind of the colored backgrounds of some of the people who have innovated these medical advances. Like really just even looking at like, I'm sorry, this is a trigger warning for any of the M2s. Some of my on-king cards, if you even look at that, they sometimes will mention if somebody is of a colored background, of like a historically ethically ambiguous backgrounds. For example, like Reiter and Wegener were Nazis, and that was noted on the on-king cards. And just having little things like that while we're learning everything, I think, is an interesting way to help, kind of to Jenny's point, acknowledge the history here without, sweeping under the rug.
Yeah, I agree. The most important thing, I think, is just acknowledgement of how we acquired this knowledge, which isn't really done in medical training at all, in medical schools or in residency or in fellowship. And I think it's a shame that we sort of have to educate ourselves as to how this came about. And I think that the medical training institution should do a better job of doing, of highlighting some of the unethical practices that led to some of the discoveries within medicine.
Hi, this is Steve Stevenson. Can you guys hear me?
Yes.
So yeah, I agree with everything that's been said. And another thing this reminds me of is the current conversation that we're having in the arts as well. I'm older and I love Sunday morning and watching Sunday morning. And this Sunday they had a whole article or a whole episode or segment on how we reconcile sort of artists, both musically and of sort of the painters and stuff like that from history, who have these sort of now past that we know about. And you can bring up recent musicians, comedians, et cetera, and like, how do we sort of reconcile the art that was sort of that they represented at the time with their known background now? And I think this is one of these issues that is sort of playing out across different specialties, and I think we can also learn from that as well. But I agree with everything that's been said in terms of, particularly in medical education, how can we begin to highlight some of these issues historically?
Thank you for that. That's actually really well said. We do see this in the arts. I know that it's been happening in like the development of AI. So there's tons of examples of this. I do want to point out, though, from the description of Bartholomew, he sounded like a total jerk, just for the record. Okay, so the next thing I want to talk about is Arthur Wentworth and lumbar punctures. So in August of 1895 at the Children's Hospital of Boston, there was a 2-year-old girl that was described as having a doubtful case of meningitis due to tuberculosis. Wentworth identified her as a candidate for the first ever lumbar puncture. Some sources claim that parental consent was not given at the time, and Wentworth just went ahead and did whatever he wanted. The description of the procedure is pretty brutal by Wentworth's account. He himself states that he felt an uneasiness during the procedure. The child was said to have thrown herself around on the bed while pulling at her hair and crying. Her heart rate rose to over 250, and she was then given subcutaneous injections of brandy and ether, as well as heat. The child wasn't sedated through this whole ordeal at all. Anesthesia was invented in 1846, so almost 50 years prior to this event. And Wentworth just decided not to offer this to this child. So I also included the picture of the anatomy that you'll have when you're doing a spinal tap or a lumbar puncture, just to kind of give you an idea of what that kid went through at the time. And Wentworth, I believe, I think he either was an educator at Harvard or graduated from Harvard. I don't recall, so don't quote me on that. So initial thoughts. I'll kind of start with this. This one made me kind of sick. I mean, they all did, but this one just, I have like a soft spot for kids. So the idea that somebody could see this child and say, yeah, I'm going to do something that's painful and not offer you any kind of comfort just because I'm curious about what's going to happen is disturbing. Like, there were so many other ways to go about this, and he chose not to offer any kind of comfort or protection to that child. And it makes me wonder, did he even see this kid as a person, as somebody who could feel things?
You know, Victoria, it's just really disturbing, because all I was thinking, honestly, while you were talking about this was, you know, the Hippocratic Oath that we give, and that, you know, that one statement, do no harm, is just like, I was really just thinking about that the whole entire time. And I was just like, how could, you know, someone do that to a child and know that they're in pain? You know, they're obviously, you know, in serious pain, and you're just, you know, going forward with it. It's just very strange to me, you know, the frame of mind that these people are in when they're conducting these types of experiments, because like you were saying, you know, maybe they were not thinking of that child as, you know, equal to them. But, you know, I feel like it, even if you weren't, why would you want to, you know, hurt, you know, anyone in that type of way? So it's just a lot of things just going through my mind, just thinking about that, just, you know, how it's so counterintuitive to our roles as physicians. So
we're told we're supposed to be these protectors and uplifters of people's health. We're supposed to support people. And there are so many instances of us just not doing that and actively harming people. Yeah, the Hippocratic Oath, I don't know how somebody can take that oath and then do something like this. Yeah. So my next question is, what is a vulnerable population within healthcare? And I think this child falls into that category of a vulnerable person.
I mean, I'm sorry.
Go ahead. I'll go after you.
I was, when I looked at that question, I really was just thinking about all the marginalized populations that I had worked with when I was in the Bronx. And one of the most common things that was mentioned to me is the major distrust in the healthcare system. And it could be anywhere between like a lack of cultural understanding, a language barrier, it could be just so many things. But there is a huge distrust between those marginalized populations of people and healthcare. It's not even just, you know, the lack of access or you know, the other things that I mentioned. There's just so many other things that that needs to be worked on in those areas of America.
Yeah, I was just going to say that in healthcare, vulnerable populations really just a group that's an increased risk of just receiving disparity in medical care. And it can be based on age, race, gender, ethnicity, sexual orientation, etc., or socioeconomic insurance status. I think this has been brought to light again in the midst of the COVID-19 pandemic. I know that here in Chicago, and even in the vaccinations that are occurring right now, here in Chicago, on the south side of Chicago, you know, it's predominantly African American. This is where the highest rate of death is from COVID-19, but it's also the lowest vaccination rate right now. And even in terms of, you know, access to vaccines, there are just more vaccinating centers on the north side of Chicago than there are in the south side of Chicago. And it's just really a systemic problem, I think, within America. And we've just not really done a good job of, you know, addressing our vulnerable populations in terms of access to healthcare and even life expectancy. Like in Chicago, since I live in Chicago, I know a lot of Chicago facts, but you know, on the south side, 2 miles away from the north side, there's like 16-year difference in life expectancy, 2 miles apart. And it's really just due to, lack of supermarkets 2 miles away from the loop, lack of healthcare. Hospitals are being closed down on the south side, but not really on the north side, so patients have to travel longer distances. There are a lot of factors, and I think that we just need to actually invest more money, resources, et cetera, into our vulnerable populations in general.
You mentioned the difference in life expectancy between places that are really close in Chicago. So it's the same here in New Orleans. And there's a place called the Ninth Ward, which is the place that flooded during Katrina. And then there's another place called Old Metairie. They are less than 15 minutes apart. The difference in life expectancy is almost like 20 something years. In Old Metairie, you will live into your 80s or the national average. In the Ninth Ward, if you make it to your 60s, you're considered lucky. It's just a stark contrast. And if you go out there, because I've driven out there before, the food's great, there are no supermarkets. There is not a single, like if I wanted to buy an apple, I would have to trek all the way across to get one. And when you look around, these are these families that have stayed here. They've experienced this. Katrina, I can't describe what Katrina was like, but everybody who's from New Orleans will describe it as just this absolute nightmare. And these people survived that, and they stayed in their homes, and they don't have the same access as everybody else. They don't have as many, they lost everything, and they're still rebuilding to this day. It's been almost 15 years. So to add the added bonus of not even giving them something as simple as a grocery store is ridiculous. And I also would like to mention, I think it is an absolute privilege to be a provider, to have somebody trust you with their health and their vulnerability, and you can help them. And I feel like that's not something that's appreciated as much as it should be, and respected as much as it should be. Something I saw that worked, at least here in the New Orleans, for the vaccination rate is Dr. Laborde partnered with the churches in these really vulnerable areas. And we went to churches and were giving out shots. And it was just the sweetest little old ladies who come there for Sunday church getting their shots, and they would be happy and excited. And it was a common thing to hear, like, oh, I'm so glad this is here because I couldn't make it to the main hospital or the main vaccination site. So you really just have to invest your resources, as you were saying earlier. I could talk about this forever, so let me move on for the sake of time. So one of the most notorious experiments is the Tuskegee Syphilis Experiment. I say notorious, but I was actually never taught this in medical school. I had to go and look for it on my own. And this horrible experiment spanned 4 decades, where what ended up happening was the Public Health Service, or the PHS, and the CDC wanted to study syphilis and its progression. So they collaborated with Tuskegee University and historically HBCU, and identified 600 participants who were all Black sharecroppers in Alabama. To explain what a sharecropper is, they're like a tenant farmer, and they live on land that they don't owe, and to pay their rent, they use their crops as currency. So these people don't have access to consistent medical care or even medical knowledge. And of those 600, 399 participants were infected with syphilis, or found to have syphilis. The researchers did not tell them that they had syphilis. They intentionally chose to withhold that information. Oh, by the way, while this is all happening, penicillin was invented in 1928, before this even happened. So we had the cure for syphilis, we just chose not to use it. And these researchers let these people continue on without telling them their diagnosis, blocking them from getting adequate care. And a couple of these participants were drafted for World War II, and the military found that they had syphilis, and it's standard procedure to treat your soldiers for syphilis when they have it. The PHS went out of their way to have these people from the study removed from that list to receive care. So they really aggressively just wanted to watch these people suffer just because they were curious. Anyways. So by the end of the study, 128 people died from syphilis or its complications. 40 wives were infected, and 19 kids were born with congenital syphilis. This does not take into account how many people were infected as these people progressed through their lives and had sexual relationships outside of marriage. And this is not just oh, it hurt a couple of people. This hurt generations. And Bill Clinton said sorry in 1997. He held a ceremony, and we did get regulations to protect people from this happening again. But the 70s wasn't that long ago. That was within some of our lifetimes and some of our parents' lifetimes. So pretty disgusting experiment, if you ask me. But that's just what I found in passing. So knowing this, how does medical mistrust in Black/African American communities impact the ability to deliver neurological care? A quick statistic. Black people are much more likely to know what the Tuskegee Syphilis Experiment is than white people in this country.
Yeah. I won't really talk about neurological care, but I'll just talk about medical care in general, since we are talking about COVID. I will say that on Facebook, with the vaccines, there were several Black people that I know who stated that their reason for not getting a vaccine right now was because of the Tuskegee Syphilis Experiment, which you're right. I think over 50% of Black people they've polled actually know about Tuskegee, but I feel more actually at least know the name of the Tuskegee Syphilis Experiment, even if they don't know exactly what happened. Because as you mentioned, this was not that long ago. This ended in the 70s. My parents were alive. People are still alive, grandparents, parents, etc., who actively know what was done at that time to a large group of African Americans. And this study has directly impacted just trust, I think, of Blacks in healthcare in general and also in research studies. So it's something that even though this was 1932 to 1972, this is something that I was actively talking about even a few weeks ago in terms of just getting a COVID vaccine among the Black community. So the medical mistrust is still there, it's pervasive, and it's there for a reason, right? Because there are people who've lived this experience or have parents who have and are still distrustful of all of medicine and healthcare.
I don't blame them is my short answer, because we consistently not only we let these people down, but we actively harm them. When we were doing the vaccinations here, it is not uncommon to have Black people that are concerned, hey, I don't know what that's going to do to me, and I don't want to be another guinea pig. And one of the things I have to or one of the strategies that I've used, it depends on if they're a younger person who would get what I'm saying, but I tell them look, we have people very rich, very affluent white people rushing and cutting in line to get these vaccines. So if they're willing to get stuck in the arm and they're not the ones who are guinea pigs, then it's probably safe if we're giving it to these people who have historically been protected and treated with quality care, as everyone should be. And it's very frustrating because something that people did relatively recently ago continues to hurt an entire community. I can't imagine what it was like to find out later that I had been infected with this disease and I passed it on to my child or my spouse, people I cared about, and there was a cure and they just refused to give me a cure, that an institution chose to condemn me to a painful disease. It's frustrating.
I'll say one of the misunderstandings about this, the syphilis experiment itself, that's pervasive, I think, in the Black community was that Black and African Americans were actually injected with syphilis, which didn't happen. But I think there was also a survey that showed of those who knew of the syphilis experiment, most believed that the participants had been given syphilis. And I think that belief too has also led to, just the distrust in vaccines in general in the Black community, to not be experimented on again, basically.
And that's actually something I heard, that one of these theories is that if you get the shot, they're infecting you with COVID to see what would happen. I've actually heard that from a couple of people. So that would make sense that that's a sentiment that's held. But you're absolutely right. There, in the Tuskegee syphilis experiment, people were not infected with syphilis. They were identified as having it when they entered the study. So going on for the sake of time, does anyone have any experiences with medical mistrust, either in your interpersonal life or in the clinic?
I mean, I wouldn't say personally with me I have medical mistrust, only because, you know, I am a physician now, and I don't really, you know, I can't really remember a time when I did actually have that type of distrust, just because I had so much respect for physicians in general my entire life. But I did experience that with patients. I was actually doing my neurology rotation, and one of the patients that we had ended up with a subarachnoid hemorrhage because she did not want to take her blood pressure medication anymore. And one of the reasons why she didn't want to take it was because she thought that that was a way for her to be like financially bound to a hospital or to, you know, a doctor's office by having to constantly come in and like go through the whole insurance thing and, you know, having to take all these medications. So she stopped taking it because of that. And unfortunately, she ended up, you know, dealing with the consequences of that. But the main reason was because she just did not want to take those medications. And it was mainly because she did not trust her physician. She did not think that her blood pressure was as serious of a problem as her physician was kind of pushing it out to be. And she just kind of brushed it all off because she didn't think it was going to be that serious. And so I've seen that really several times throughout my years in med school. And it is really concerning that it's not just one or two people. It's, you know, large populations that just have so much mistrust in the medical community. And I think it's not their fault. I don't blame them for feeling that way, because like we've seen in history, it's, you know, kind of played itself out to, you know, having people gain that mistrust. I mean, I think there's definitely a reason. It's not like, you know, it's not happening for any type of reason. So
I think a potential solution to this mistrust that I've actually seen is I was working in a neurology clinic with Dr. Davis, and she would actually take the time out of her day to address any concern somebody had about the vaccine. And I heard wild theories. I heard, oh, the Pfizer one is made with like dead children, all kinds of things. And without judgment, without, I guess, chastising them or speaking down to them, Dr. Davis would sit there and be like, well, let's talk about it. Those were her words. Let's talk about it. And she would remain calm. She would give them space to speak and then say, well, this is the data. But she would also make a point to mention, like, look, I don't have any stakes with these companies. Like, I don't get anything from this. I just want to make sure you're safe because I'm tired of watching people get hurt. Mm-hmm. And I think just taking the time to really convey to your patients as best as you can that you care about them and that you want them to do, you don't want them just to be healthy, you want them to be happy and healthy. Just keep hammering that point home, and hopefully eventually they trust you. And we can prevent things like that from happening.
Yeah, I think as physicians, we're trained to be advocates for our patients. So one of the biggest things I think, you know, that needs to be worked on is just, you know, allowing that conversation to happen without any sense of judgment whatsoever, and addressing every single concern that the patient has, no matter how, you know, ridiculous we might think it is, or, you know, whatever, just kind of addressing it and not dismissing anything. And I think for, you know, every person who is a physician, it can be difficult because, you know, every patient is different. All of their concerns are different. So I think just having that patience with every single patient is key.
Does anybody have anything else they would like to add before I move on? Again, yes, go ahead.
Yeah, I was just going to share an experience that that I had. So I guess it was more so me witnessing this play out. On my family medicine rotation.
I'm sorry, Doctor, can I interrupt you for 1 second?
Yeah, for sure.
Of course. Yeah, no, I just want to say, so first, I just want to say thank you to our guest panelist here, Dr. Starane Shepherd. I just want to be respectful of his time here. So it is 8 o'clock, which is when we were projected to be done. I'm happy to stay on and have this discussion with you guys for a little bit, but I just wanted to make sure that we all give our thanks to Dr. Shepherd if he needs to go about the rest of his night.
No, I'm good for now.
Okay, great, perfect. Sorry, please continue then, Diamond.
Sweet, thanks, Phil. Yeah, lost track of time there for a second. But yeah, I was gonna say that I kind of had an experience just witnessing this. I work with a clinician right now on my family medicine rotation who kind of talked to me about how he's wary of the patient sometimes he gets referred to or come from a colleague of his, given that patients of color in particular have found it difficult working with his colleagues. So we had a conversation about how the steps to take to rebuild that trust and understanding that, some of the concerns that they have are valid and how it affects them, and the work that, the other clinicians have to do, he has to do in order to establish that trust with them again and hear their stories, which was, appalling, surprising to me on a couple levels that, there's that this is something that there's a level of awareness about, but also that, it's affecting people to this degree.
Thanks for that, Daimler. I want to ask which clinic that is, but I'll leave that to another day. We'll catch up. Me and Daimler are classmates, just for the record. So I'm going to jump to the next slide. And
actually, can I just add, sorry, can I add one more thing, Victoria? Just
go for it.
Just to bring this back to the context of neurological care, just an experience that I've had with something similar to this and medical mistrust and everything. I think it is interesting to consider, and this isn't, I'm not just pinning this on, the Black and African American communities specifically, but I think anecdotally at the very least, there is a correlation between kind of access to health education and the communities that have reasons to have medical mistrust, historically disadvantaged communities that I think can really present itself sometimes kind of with what Jenny had said when you sit down and address problems with people. Jenny and Victoria both mentioned that. We did have one patient when I was shadowing in undergrad in an inpatient setting. It was someone who had a bad flare-up of MS, who was basically diagnosed on the spot when I was there, and had become like kind of irate after finding out, and basically like refused to let residents touch them from that point on. There was it was a Black gentleman. It was clearly kind of just going through it, and I think there have been some viral Twitter posts about the same thing that no one really bothered to swing back around and say too much about it. They basically said like we'll be back in a little bit to explain it to you, and one of the residents ended up going back in the room a little bit afterwards to kind of explain what MS was. Very similarly, I think I see Victoria smiling. I think she's seen the.
Yeah, I know the story. Yeah.
This was actually like a very similar story that someone just took their time to explain something to them, and I think helped expand their education of the whole situation. And that wasn't necessarily something where they were totally cool with it right afterwards. This isn't storybook. There's a lot more work that needs to be done than that. But it seemed like it at least helped them to be more accepting and open to the care that comes afterwards. So really, very compassionate care, and was really impressed by that resident.
So the other thing I want to mention before I get into this report is those stories, when I read them, they make me so happy that I really genuinely hope that we all kind of go on in our respective careers to just be one of those people for our patients, because I really feel like it helps them to really take control of their health and understand what they need. And it also it helps them advocate for themselves. Like, how can I advocate for myself if I don't know what's even going on with me? So if you see something, say something, I guess, kind of fits that category. So, Flexner Report. This is actually something I didn't know about until relatively recently, I think earlier this year. And the Flexner Report is this report that standardized medical education. It was written by Abraham Flexner, and he was backed by the Carnegie Foundation. So he was the one that proposed these 2 years of preclinical training and then 2 years of clinical training. And we still have this structure to this day. When he wrote this report, he chastised the South for its medical education and displayed like a really intense distaste for farmers and like rural poor people. He proposed this like new academic calendar that intentionally barred farmers from being able to enter medical school. So previously, before this report, medical schools were set up to allow people to have time for the planting and harvesting seasons. So if you were a farmer, you could start your crops, go to school, come back, and then harvest, or if you worked on a farm, and it would allow you to do that. But the Flexner Report and the change to medical education stopped that from happening and barred that group of people from accessing it. And by his standards, there was not a single Black medical school that met his criteria in the entire South, not a single one. And he offered absolutely like next to no financial solution about how to help Black programs adapt and how to support them. Because the change to medical education was described as inevitable. And he acknowledges the need for Black doctors, but intentionally states that they should focus on hygiene of their Black patients rather than do surgery or be procedure-based. And his explanation for why Black physicians should focus on hygiene is very wild, but it's because he didn't want Black communities that live in proximity to white communities to infect the white communities. That's not like an exaggeration. That was the sentiment that was held. And I also kind of want to point out that at this point in 1910, segregation was still very much alive. So by closing all of these Black medical schools, none of the medical schools that were still open were going to let Black students join the classrooms. So you basically completely shut out this group of people from becoming doctors. Where was I? He also mentioned Black women in a single line, and it was just about them being nurses. That was it. But he was supportive of women, specifically white women, becoming physicians. He created the structure of the elite medical school we see today, which is really only accessible to white affluent males. And we still see that kind of trend in medical education to this day. So that brings me to my next point. So knowing that the Flexner Report exists and has been the standard for over a century now, these are the current demographics in the US for medical students. And white people still form the largest group within medical education between both genders. And we can't look at medical student demographics as simply white versus non-white. I think categorizing all people of color as just non-white when you look at statistics is a disservice, and it erases their cultural identity and their experiences, which affects their ability to progress through life. And that kind of furthers me to, if we look at the Asian demographic, just that category alone ignores the cultural differences between South Asians and East Asians. And if we made that distinction, I think that number would look very, very different. The only positive thing about this chart, or one of the positive things, is we see that there's more women in medicine as time progresses. So that's a good trend, but the hope is to see the demographics of medical education be spread out throughout people, just of various backgrounds. Which kind of brings us to the next point that I'm going to make is having people of various backgrounds. We know that diverse medical providers have better outcomes. If you represent your community will have a better outcome. So why is it that adequate physician representation of historically marginalized groups important in the effective delivery of neurological care? Phil, just to come back to that story you were mentioning, the viral story, that physician, both men were Black, and the ability to connect with another person because they understand where they're coming from is the whole reason that resident was able to explain what was going on with that patient and just be able to connect and represent that person.
Yeah, So I have a story also. So I do neurocritical care. So I have a lot of delirious patients, subdurals, etc. And I had a patient who is an older Black male, born in Mississippi, who every evening would sundown and would need to be physically restrained and or chemically restrained with Haldol. And I remember walking into his room and he looked at me and said, "Why are you working with them?" And I was like, "What do you mean, why are you working with them?" And he was like, "The KKK. Like, why are you working with them?" And I don't think anyone really realized that every evening when he was having all of these white nurses and everything tie him down, he was reliving his experiences growing up in the South. Which struck me, but yeah, and it's something that I still remember to this day. I think it's really important for us in healthcare to resemble our patients, because at least we have a better understanding of what they're going through, be it, women or the LGBT community or BIPOC, just because we have a perspective, being underrepresented within medicine that others do not have. And it's really good just to be able to connect to our patients and try to understand where they're coming from. Because honestly, without some of the experiences that we've lived through ourselves, we won't be able to understand what they're going through. So I really do think that, medical schools in general, residency training programs, like every level should really seek to ensure that, they're diverse at all levels. It's the only way we're going to move the needle forward.
One of my favorite moments, or like reassuring moments in medicine, was I was rotating through an ER in like rural Louisiana. And these two women, they're Black women, and they're just the most adorable little kid, came into the ER. And the kid had managed to make it out of the door. And the neighbor, who had like an interpersonal conflict with these women, called the police. So the police brought this kid in. Kid was totally fine, just a little sniffles. And I went in there to kind of hear what was going on. And we're chatting, and I'm getting along with them because I kind of can relate to them and how they speak to people. And they just reminded me of my own family and how we talk to each other. And when I went to go get the attending, who was a white physician, he came in and he was just asking them some questions about safety and if CPS needed to be called. And the entire time when the women were speaking, they were speaking to me. They would look at me, they would address me. And it got to the point where the doctor was actually upset. And he said, "I'm the physician, she's a student." And he redirected that interview. And it felt really good to have somebody look at me and be like, "No, I trust you and I want to talk to you." Because I'm like, I understand where you're coming from, or to some degree, I understand where you're coming from. And I know what it's like to be in a situation where, that entire ER was just white providers. And I was kind of the token at the time. And having somebody else who's like, "Well, these people can't relate to me, but maybe you can," was a really good feeling. And it reminded me of why I wanted to do this. So a little frustrating that doctor got so mad about it and he couldn't really see why they were talking to me, but that's a whole other thing.
I mean, that goes both ways too, right? Just having done training in Boston, there were times where either I would walk into a room or a female, resident or fellow would walk into the room, and the patient would not want to speak to either of us, unless either because it was female, right, and the perception that all doctors are male, or because it was a person of color. So even this is kind of answering the number 2 question, right? I think we've all experienced bias and prejudices in medicine itself. Part of the reason why I think people of color tend to wear white coats more often than people who are not, and also females within medicine, just to make sure that the patient recognizes that you are a physician, or a nurse practitioner or PA, whatever you are, just that you are who you are, just because you have to just make it be known more than people who are not underrepresented within medicine do.
Mm-hmm. Daimler and I had this particular experience back in Australia where we did our preclinical years, and we were on the wards, and there was this really older gentleman who he cut cane, or let me say this the right way, he cut sugar cane for a living, and my family's from the Caribbean. That's all what my uncles did. That's very common in my family. So I kind of understood where he was coming from, but he was in complete awe. There wasn't a tint of malicious to it. It was more of like he just didn't know. He was genuinely shocked that me and Daimler were from the US because he had never seen someone that looked like us with American accents. And he's like, this is a guy who's from some rural middle of nowhere place who's done physical labor his whole life and is very deaf. So I had to scream the entire time. And he was just in complete awe that there are people that he'd never met that are from places that he could never imagine. You know, I told him I was from Florida, and he's like, no way, I would have never guessed. And he was completely shocked. And he mentioned other medical students. It was, I think, an East Asian woman. And he was like, I thought all East Asian people come from this place. And she told me she was Korean. And it's wild how little exposure some people get, and they only go off of what they see on TV. So they have these preconceived notions of you, and when you don't fit that category, or they don't expect you to be this person, they're in shock, and they can react and this guy was kind of positive, or they can react in a negative way that you experience where they don't want to talk to you. And both in and of themselves are very layered, is the short answer.
I vividly remember that experience. I forgot that we had shared that. And yeah, I definitely agree about what you said on those lines. I just wanted to throw in a quick fact while I was Googling over here. So apparently for the last 60 years, the AAMC has been awarding the Abraham Flexner Award for distinguished medical education. So, and 2021 is going to be the first year when they renamed the award, which kind of blew my mind that it's literally just happening now.
Yeah, very, very frustrating, is to say the least. So that let me move on for the sake of time so I don't chew up too much. So what does all this mean? This whole thing is layered. So with these historical beliefs we touch base on, we actually have continued false beliefs that there are biological differences between BIPOC and white people. Dr. Shepard already kind of talked about the study I was going to mention, but the 2016 survey of residents and medical students found that almost half of them held some antiquated belief about there being a biological difference between races. And then when they furthered that study, they found that those people who held those beliefs were less likely to adequately treat their Black patients' pain. And this is terrifying because this is not that long ago, and these people are probably doctors now treating Black patients. And if they're not addressing their biases or not aware that, hey, that claim I believe is totally false, they're not giving their Black patients the care they need. And that's kind of terrifying. The other thing was this. We see this trend of blatant disregard for vulnerable patient populations and apathetic attitudes towards our patients. You know, Wentworth and Bartholow as researchers and physicians, they didn't even offer any comfort care to their patients. The Tuskegee experiment didn't even have the decency to tell these people that they were sick with syphilis. The researchers of the Tuskegee experiment actively refused to treat their participants, and they let these people suffer. Wentworth didn't care to sedate this kid. Bartholow didn't even feel that he had to document Mary's death, but he was able to shock her and describe all of that. And Bartholow and Wentworth went on to teach. And that's concerning because those attitudes that they hold, they will teach those to medical students. And those medical students grow up to be doctors, and they grow up to be educators, and then they teach other medical students. And we just have this perpetuation of these terrible attitudes towards patients and this apathy and disregard for them. And as we continue to do that to our patients, they don't trust us. And a really good example is, the Black community does not trust the institution of medicine and research in general as well. So what we're seeing is in research, the participant demographic is predominantly white. Black communities are underrepresented throughout research, and this confounds our ability to treat them, because if we don't include them in our studies, how do we even know what their needs are? And it's that mistrust where it's like, well, they don't trust us, so they don't participate, but we still do these studies anyways, and we don't know what their needs are, so we continue to not to give them the care that they need, so they further distrust us. And it's a vicious cycle, and we have to actually take the time to sit down and try to end it. And in addition to treating, like the institution of medicine treated Black people, women as lesser and as guinea pigs. And then we went on to bar them from getting into medical school with the Flexner Report change. We made it harder for these groups to get into medical school, so they couldn't even represent themselves as physicians. And it just builds onto this inequity and disparity we see within all of healthcare, not just neurology. So what can we do about it? There was a paper titled Inequities in Neurology Amplified by the COVID-19 Pandemic by Nolan and colleagues. And in that paper, there was this really good infographic that breaks down the multiple levels of racism and describes the barriers to care and the barriers to quality, so access and quality, and how they contribute to disparities. While this specific infographic is for racism, I think you can interchange racism with misogyny. And then I've never pronounced this right, but the misogyny, where it's like the cross between racism and misogyny, which is a whole other lecture. But I like this image because it shows us the tiers that racism really bleeds into, and it goes all the way down to our interpersonal relationships. So you have interpersonal, which is like our own experiences, our own biases. Then you have institutional, which is our community infrastructure, which is hospitals are far away from, or at least here, the main hospital is far away from the 9th Ward. So the poorest neighborhood here can't get to the hospital if they need to, or their communities don't even have grocery stores. And then you have systemic racism, which is a mountain that would take days to explain. So that brings me towards the end, and I don't want to chew up too much of your time, but seeing these questions, you can start with whichever one you would like, but how do we address either interpersonal racism and misogyny, institutional, or systemic? And then obviously, if you have any questions, please feel free to bring them up.
So I think that we start to address any of these things by first acknowledging it, be it systemic, institutional, interpersonal. Like, we need to have conversations, which we're doing. And I hope that these conversations continue. And we really just need to bring everyone to the table and talk about it. In our medical schools, we need to do a better job of addressing the inequities and disparities that exist within healthcare and our vulnerable populations, be it based on race or LGBTQ or anything else. In our residencies, we need to, in neurology, we need to talk more about the history of race within neurology and the history of vulnerable populations within neurology. I think even at our faculty level, we need to seek to actually attract and retain, people who are underrepresented within medicine, so that we have diverse faculty to teach our trainees. This isn't going to be, this is something that's been pervasive for a very long time. Really, it's been in the building blocks of the creation of medicine and healthcare within this country. And I think it will take a long time to dismantle it, but we need to start, and we need to make every day about making healthcare more equitable for all, basically.
Continuing to have these conversations is a fantastic strategy. I think what people don't expect, though, is the discomfort they might experience when they have this. Talking about your own biases and pointing out, like, that is a flaw within yourself. That is really hard to talk about. It is really hard to say, yes, I'm a biased person. My views can be harmful to other people. And it really takes time to really look at yourself and decide, hey, is my thought process or my assumptions about people okay? And they might not be. So the whole process of addressing institutional, systemic, interpersonal racism or misogyny, it's an uncomfortable process, and people are not going to like it. And we already see kickback from this. I forgot which podcast it was that says doctors weren't racist, that whole thing, and then the apology was kind of laughable. But that kind of just shows you the discomfort that people feel when they have to be accountable for their own decisions, their own thought processes. And the system, medicine was not built it's not an abstraction. It's built by us as individuals. And if we work at the individual level, then as we gain, power in our career and we progress, we start to make institutional changes. Like I will become an educator at some point in the future, hopefully. But if I become an educator, I can have these discussions with my medical students and my residents if I get to that point. And then if I progress even further and I've educated all these people, we can collectively address systemic racism with really specific and targeted approaches. But it's not going to be pretty, and it's not going to be fun, and people are going to get real uncomfortable about it.
Just to kind of bounce off of what Victoria was saying, I would say, as far as addressing interpersonal racism and misogyny, I think one of the most important things for us to do is address it when we see it. And, if you're seeing, a patient that you feel is not being treated fairly, to speak up and to defend, that patient, defend, yourself, defend, whatever you need to do without any fear of being reprimanded or punished. And I think that's why perhaps some people might turn a blind eye to some of these things when they see it, because of fear of being reprimanded by either, their attendings or the administrators of the hospital, et cetera, et cetera. But I think there really needs to be like a zero tolerance policy when it comes to those types of things. And I think as far as institutional racism, I think that has to be addressed at an administrative level where residents can feel like they can openly talk about these things and be honest about what they're seeing. Because I feel like the administration could very well not even be aware that these things are going on because they're in their offices in a totally different part of the hospital. So I think it's really important to address those things too, to have meetings like this that are addressing these things specifically and seeing, is there something that needs to be done? Is there any training that we maybe need to give before these people even enter residency? And so those are some gaps that I feel need to be filled within institutional racism. And then as far as systemic, that definitely needs to be addressed within a policy making level, where there are policies put in place and enforced to ensure that these things are not happening. Because I think really the reason why these issues are still going on right now is because they're not being addressed adequately. They should not be going on right now. And so that's kind of my 2 cents on it, but it is quite it definitely is a lot of work that has to be done. That's for sure. And I think everyone needs to be on board in order for it to work.
You bring up a really good point about being afraid to say something. And I think what happens in medicine a lot is our administrative staff will weaponize professionalism against us. And it is hard to, medicine's not pretty. It's not. There's blood, there's guts, there's all kinds of gross things. And it is hard to really package that into a nice, polite form when there are things going on that hurt people. I don't want to write a friendly email when somebody's being, racist. They're not giving people adequate care. I should rightfully be upset about that. I should rightfully be angry about that. And I shouldn't coddle the person that's committing these things. Maybe at an institutional level, there should be an anonymous reporting system. But even in that, that's flawed if people might be able to find out, hey, who said something? So the culture of medicine is one that stifles complaints a lot of the time. And I think yeah, I think you're right. The going to the admin and saying, hey, you don't see this, but it happens and you need to be aware of it and you need to address it might kind of change that culture within medicine, at least in medical schools. I don't know about residency yet. We'll see when I get there.
I will say there is an anonymous reporting system, but you are right in terms of you can be discovered and, you know, there can be repercussions for anonymously reporting things within hospitals. Yeah, but I agree that you should speak out. Yeah, and it's really the only way that you're going to address these things is to address it head on and be vocal about it.
Yeah, and I just feel like there should not have to be an anonymous way of addressing these things. Like, you should be able to know who I am. I'm going to address it, and this is what we need to do about it. It should not, you know, have to be anonymous. I think, like, no one is perfect, and just, you know, holding each other accountable is very important, and ensuring that our patients, above all else, are receiving the care that they deserve and that they need should be of the utmost priority. So
I forget where I learned this, but somebody described, it's probably been described multiple times, that racism and misogyny is actually a patient safety issue. And I think structuring it like that, I agree with you. I'm a person that likes to say things with my chest, so I would not be anonymous. I'm like, you should be able to know I said it. But framing it as like a safety issue is a potential route to kind of bridging that conversation and speaking about and acting on that, because patient safety, there are so many seminars in hospitals about patient safety, about fall risks and all of these things. Well, isn't an implicit bias, that unaddressed implicit bias or unaddressed systemic or institutional racism a patient safety issue? So that might be a potential route to kind of start to work on these things. I do want to be really conscientious of everyone's time. I've already gone over by quite a bit. If you have any questions, I'll hang out for a bit and I'm happy to answer them. Otherwise, I don't have anything else for all of y'all, but thank you so much for coming out today. Dr. Shepard, it was great to have you here. You drove this discussion and added a really powerful insight to it. Jenny, you were killing it with your answers. I really like that. So thank you all for coming out tonight. And also, here are my references if you need them.
Okay, thank you and have a good night, everyone.
thank you.
Take care.
Thanks so much, Dr. Shepard.
All right.
Yeah, and sincerely thank you everybody for coming on and, you know, having this discussion with us. All right.
Thank you guys so much.
Of course, Jenny, take care.
Take care.
Thank you. Thanks, Phil.
Yeah, no problem, Daimler. See you tomorrow.
All right.
Sweet.
Solid. One day down.